A very warm welcome from wherever you may be joining us. It's afternoon in Nairobi. It's about just after 4 o'clock. And so we welcome you to this session. It's a series of sessions that we've been hosting with our partners, HBGI, around mental health, specifically mental health investment on the continent. So you will have noticed in the chat that we've asked you to put in your name, the organization that you're joining from, and where you're joining from today, and any your LinkedIn, and I'm sure lots of people will be able to see who's here and where you're all joining from. Also, feel free to use the Q&A functionality at the bottom of your screen. Sometimes you hear something and you think, that was a question that just popped up in my head. So use the Q&A function. We're going to keep an eye on that as we go along. We request you just to stay on mute so that we can hear from our great panelists today. And this session will be recorded. So in the event that you need to revisit the content later, that will be available once the session is over. We try and make the sessions as interactive as possible, so there will be polls that you can participate in. Some may make you oh and arm a little bit, and that's the whole point. It's meant to kind of check where you're sitting at in terms of your understanding or some of the knowledge around this space. In the event that you do want to share what you're hearing or that you were part of this discussion today, the webinar hashtag is on your screen, hashtag mental health outcomes. My name is Nasri Adam, and I'm the Director for Impact and Communications and the Regional Director for East Africa. As I mentioned, I'm based in Nairobi, Kenya, but there's a whole team on this call. You don't see them, but everything that you see happening today is part of a really super team. We are based in Nairobi, Johannesburg, and in Lagos, Nigeria. And our whole reason of being as an organization is how we can drive more investments towards social impact on the continent. And late last year, we had the lovely opportunity, the lovely fortune of being part of the Coalition for Mental Health Investing, and something that we're very proud of as an organization. And as we started to think about what are the practical things that we can do, it became apparent that there isn't enough information or data or spaces of learning around mental health investment. And so we thought, why not start there? And so we've been running a series of webinars. This is one in the series, thinking about how we can be able to offer more information around mental health investing. The first one was around outcome-based financing in mental health. And today we're about proving impact and measuring mental health programs, and there's more to come. So stay tuned. If you aren't following us on our socials and our LinkedIn, that's where we're sharing a lot of this information. So feel free to subscribe to that. Um, just changing gears a little bit, seeing some familiar names. It's lovely to see you, Kathy Trialogue, joining us today. It's great to see you join us. It's good to see the Save the Children team with us today. And we have some joining all the way from the States. We have Kenya joining us. And just keep putting it in the chat. I think you're going to find that this space is actually quite rich and lots of different people doing very interesting work. And so I encourage you to continue to put in your information. We have Laura coming in from the UK. A huge welcome. And so the objectives of today are really, if you will, quite direct. How do we define key metrics for mental health interventions? How can we find some very practical, real world examples to track mental health outcomes in this work? How do we be a bridge or a gap between investors who are looking for this data so that they can validate their business proposition, they can de-risk an investment, and providers collecting that data? And how do we explore policy and tech enablers for scalable mental health measurement? So the numbers that you see here are, unfortunately very daunting when it comes to mental health investing on the continent. It still remains one of the most underserved. And we see that mental health is almost treated as a nice outcome of a program, right? Instead of that deliberate sort of intervention from the beginning of the programming or the structuring of that intervention. So as this funding gap continues to grow, and we understand that we are facing, on the continent, stigma and cultural beliefs, limited infrastructure, substance use and youth mental health issues, as well as a huge youth unemployment across the continent, then this is something that we cannot ignore or think about later. And with those comments, I'd like to sort of change to our next slide. And just take you through what the program is going to look like. I've taken a couple of minutes to set the stage and welcome you all. And we're going to have Stacey Ann come in and talk a little bit about the measures in mental health along the results chain. It's a very fascinating area, and Professor Dr. Wim Delver, who will also be here talking about analyzing that mental health data into meaningful insights. Thirdly, we'll have Jules Chappell come in and talk about what mental health metrics move capital. In some of the pre-questions that came before the webinar, we did ask you what you'd like to learn in this session. That was a favorite topic. Just how do we actually get the money in? And then we have Pavel, who will close us off, turning this data into funding and how we can measure mental health outcomes to attract funding. And so we will also offer a space for Q&A. So use that Q&A button at the bottom of your screen. Put in your questions as we go along. So there will be time for that Q&A. And Dr. Shadrach Opon, who's our program manager at AVPA for Health, will be giving us our closing remarks. And so with that, is to welcome the panelists, welcome you all. We have about 109 of you on the call right now. So let's have a great session. Over to you, Shadrach.
Thank you very much, Nasri, for that warm welcome to all our participants today. We are going to call in our panelists to briefly introduce themselves and their organizations as the rest of us fill in the first 4 questions that has popped on our screen after this. So we start with Stacy, and then Jules, and then Prof. Wim, and then Pavel, in that particular order, as we respond to this whole question. So the rest of us, please feel free to respond to this as we get those introductions.
Thank you so much, Shadrach. Welcome to everybody who's taken the time out to join us today in this important conversation. My name is Stacey Ann Pele. I'm the Director for Partnerships and Performance for the Healthy Brains Global Initiative in Africa. My background is in health professions education, monitoring and evaluation and public health programs, and I'm so blessed to be here today. Thank you.
Thank you, everyone. I'm Jules Chappell. I'm CEO of Kokoro. We are a not-for-profit set up by investor and philanthropist Natasha Muller with the mission of helping to mobilize action and capital for a mentally healthy world. So I feel like I should be able to contribute on some of the questions today, which directly ask that question. I promise to do my very best.
Good afternoon. I'm Wim Delva. I'm the founder and managing director of a data science consulting firm called WIMI, and we focus on analyzing health data and supporting healthcare organizations.
Good morning, everybody. My name is Pavel Repo. I have the privilege of running a small but innovative organization based in Uganda that is really pushing to see mental health become a routine part of primary care. And I'll share at length, get a little bit geeky and nerdy with you about some of the metrics that we're collecting in hopes of really soliciting some funding and growing our impact. Really excited to be here.
Thank you very much, our able panelists. So first, we want to quickly jump into the conversation and having our first speaker come in. But on your screen is the results of our first poll. Very interesting. We will get as we continue. So allow me to invite Stacy up to speak to us today. Stacy, in terms of measures in mental health along the results chain, a lot of us are waiting to learn how outcome measures can better capture progress towards mental health. Please speak to us about this. There's a lot of anticipation in this. Over to you, Stacy.
Thank you, Shadrach. So up front, I just would like to acknowledge that our panel is full of esteemed speakers, but I don't think that we all have the answers for you today. I like some of the responses in the poll that said, actually, we don't even know where to start. And I think that's where maybe we're all starting today, is where do we actually start in this conversation? How do we create a collaborative space for us to have these discussions, not only across providers, but across ecosystem enablers as well as funders? If we could go to my next slide, please. So I would like to remind us all that we're not in the business of counting the number of products we produce, but the true measure of progress is really not about numbers alone, but it's about healing, dignity, and hope restored to people's lives. And for many of us, especially who live in low and middle income countries, most of us don't have even positive language to talk about mental health in our local dialects. So that's the background on which I think we should all start this conversation, that this is about people's lives and not just reducing it down to numbers. Thank you. Next slide. This is a very big acknowledgement. We know that there's amazing providers who do work across the spectrum of all the factors that influence and even some of the consequential factors of mental health. So we want to acknowledge that really mental well-being is determined by a range of factors. We're not able to capture all of this in standardized measures, and therefore we're having this conversation. And it really spans across the individual, family, community, and society, the ideas of collective and individual mental health. So that's the backdrop for this discussion. Thank you. Really, what we do at the Healthy Brains Global Initiative is scale mental health programs to build and transform mental health programs into being high functioning with the beneficiary at the center. And then the question is, well, how do I do that in my program? Where do I start? And we all know this idea of a theory of change, of a logic framework, of that kind of thing. But really, how we want to aim to do this and move it closer to the beneficiary and move towards measuring impact that really matters is move from a focus on inputs and outputs, which we are all very used to in normal grant funding models, towards the outcomes that really matter for the beneficiaries we're serving. And this is very important in the mental health space because it traverses across different sectors. So it doesn't only live in health, also social development, as well as other sectors being affected. And so it's important we start moving our focus towards outcomes. And then a lot of people use the word outcomes and impact interchangeably, but we know impact is further down the line. So for example, in a maternal mental health program, outcomes-based, that I run here in South Africa, we know that eventually we want more moms to come to antenatal visits before 20 weeks. We know that we want them to come to their visits after 6 days of birth, and we know we want our children to be immunized fully under 1. But that takes us a long time to achieve, right? Because there's behavioral change that needs to happen. But what are the interim outcomes that we can work on to get a mom to that place? How do we know that she's feeling well to uptake health services and make sure that her baby gets the health care that he or she needs? Next slide, please. And so really this is talking about, well, what is the differentiating factors and how does this move to outcomes really maximize things for us running programs, or those of us also looking at triaging different programs we come across and trying to compare them in the mental health space where they're so different from each other. So you'll notice in the traditional input-focused measurement, we talk a lot about the number trained or the number of services provided, the number of people screened even is something a lot of us focused on. And then the question to ask around that, is there a clear link between these kind of inputs and what our service users really want? And then are we holding on to things that are actually putting us in a box and not enabling us to be flexible and responsive to the needs of the health system and the beneficiaries? And of course, a focus on outcomes is really about a cultural shift. It's about putting the beneficiary at the heart of delivery. It really encourages you to be innovative because it doesn't matter how you meet the outcomes, but if they're meaningful outcomes to the people you're serving and you get there, that's what really matters. And then it also mitigates the risk of waste and loss. And this is a way you can manage your project in real time. So many of us defer to impact evaluations and RCTs, but they often happen too late. And so we aren't able to refine our program as we're going. And this can also help with the motivation of frontline workers. We know in mental health, our frontline workers are really the core of the work we do. Next slide, please. Now, some of the other speakers will go into this in more detail, but we just wanted to introduce you to kind of 4 areas of methodologies that we have come across in using as an outcome measure. So these are tools or methodologies, but they can be used as an outcome measure. The first one is mental health symptom screening tools like PHQ-9 or GAT-7 that we often use, and they administered to see the level of symptoms someone is experiencing. Then an intervention is delivered and they re-administered to see if there's a reduction of symptoms. So the outcome is the reduction of symptoms or the recovery of the client who is benefiting from the intervention. Then we have disability assessments like the WUDAS, and I know Pavel will speak about this more later, and it determines the extent to which an individual is limited because of their mental health challenges. And then there's a very interesting one around well-being, which is individual well-being. The reason why I really like this personally is because as Africans, we really should be moving towards away from deficit measures and into more positive measures. What does it look like for us to really thrive, not just survive or measure where we're lacking, but really leveraging of our strengths? And of course, one of the examples of what we use in our program is a spillover survey. So it's the individual influence of that person's improved well-being in their life and life chances, but also in their community. And that's a very interesting aspect, because when we know people exist within a community, within a family, and an intervention can have benefits for many people around them, as well as on their life chances. So these are some of the interesting measures that can be used as outcome measures, and you'll hear more from the other speakers. Next slide, please. Just to acknowledge as we continue this conversation, we know for most providers as well as funders, but from a different perspective, this is a continual balancing act of what are the needs of your different stakeholders, funders, beneficiaries, program staff, even when it comes to partners like the different government ministries. How do you balance everybody's needs? And outcomes-based contracting is a really good way to do that. It aligns stakeholder needs and is able to bring together people for the benefit of those we're serving the most. Also to consider in this conversation, and it's come up already in the poll, is that we need to be very mindful about what's practical for us. So if we are implementing a program, lots of us want all of our money to go towards the program implementation, which may leave very little left over for things like building an evidence base, for systems, for data analysis, which is really very important to start building the case for our interventions. And my last slide. To everyone in the room who's a mental health worker, which includes all of us who work on mental health programs, a sincere thank you for your dedication every day. Thank you, Shadrach.
Thank you very much. Thank you very much, Stacey, for that. We appreciate the work that you are putting into this. And we are going to have more of this conversation. Jules is going to come and talk to us about different funders. You have elaborated well how the balancing of the admin funders and the rest of the other partners. So before we call Joel, before we call Prof to come in and talk to us how we can then derive meaningful insights from the mental health data that we do have, let us have our second poll question on the screen as Prof comes in to discuss with us how we can translate the data that we do collect into meaningful insights that can attract funding. Okay. As we wait for the polls to come in, this has been quite a great conversation. I see a lot of us just joining. We are now at about 130 participants. A lot of people are anticipating this particular webinar to get a lot of ways in which they can use the existing data to attract more funding. So, Prof, I want to call you at this point to just jump in and discuss with us how you see different ways of analyzing data to derive meaningful insights for mental health in order to prove impact. The polls are already on our screen, and we will get more of this as we proceed. Very interesting responses. Over to you, Prof.
Thank you very much for the opportunity to share some thoughts on this, the question. And I want to echo what Stacy said right at the beginning. We don't have all the answers. Mental health is a multivariable, complex domain, and any attempt to reduce it to numerical scales or categorical variables is doomed to not really capture the richness and the complexity of mental health. So what we can do is our best to try and capture it in an efficient way and in a faithful way. But I want to acknowledge that the humanity, the stories, the anecdotes, the lived experience, the video testimonials, all of that should complement the quantitative measures of mental health and the effects that an intervention may have. Having said that, let's go to the first slide. Thank you. So this question of measuring impact or proving impact, to me, translates really into the simple question, but a very difficult one to answer. What effects did the intervention have? If the intervention didn't have any effects, then there is no impact. If it had negative effects, then it is a negative impact. And if there were positive effects, then we have a positive impact, but we still want to know exactly how big was that impact. So if we can go to the next slide. This slide is a similar, I was trying to communicate a similar idea as what Stacy showed in the second or the third slide, where mental health has a lot of factors that influences it. So if I'm isolated, I'm not socially connected, that's going to not do wonders for my mental health. If I've been the victim of some trauma or gender-based violence, if my physical health is not good, maybe I'm overweight, I have a drug addiction, all of those things may negatively impact my mental health. I lost my job, I get divorced, all of those things has an impact on mental health. But as you can see, the arrows are in both directions, because me having poor mental health, having to deal with anxiety or depression or suicidal thoughts, or maybe I have behavioral challenges, that on its own then also can have multiple effects across all of those spheres that you see there. So because I am depressed, I am not engaged at work, that means my mental health may put my job at risk, or may put my marriage at risk, or I may have some emo eating and compensatory behaviors. Maybe I lash out to my children. So there's so much, it goes in both directions. That's what I'm trying to say here. And that, of course, is important, because if we're now trying to measure mental health, we can't just pretend that it's only the central bubble. We have to measure as well as we can everything that's around it. And if we want to know what effects did it have, to do a good job, we should be measuring across the board, because maybe my anxiety symptoms are not reduced so much, but maybe my relationship with my children or with my spouse has gone up by a lot. And if we didn't measure that, it's going to look not as impressive as if we have the full picture. Next slide, please. Thank you. So theory of change is important. The quantitative version of this is, what is the causal pathway that you believe links the intervention to the effects? So you can't say, we have no idea what we're doing, how we're doing it, and how it will all have a result in positive impacts across mental, social, economical outcomes. I think to do a good job at measuring it, you have to first define what that causal pathway looks like. And then that from there, you can say, well, if I believe that, for instance, mental health leads to more engagement on the work floor, and through that leads to more job satisfaction or leads to better productivity, then we know that gives hints at what should we be measuring. So the second bullet point tries to suggest some of the things we could be measuring to try and capture all of the effects across these different spheres. So for instance, maybe my mental health, as it is poor, I am not very active. As my mental health goes up, I can be more active. That should translate, if I have a smartwatch, that should translate into me doing more steps, for instance. So we can begin to think, oh, maybe the step counter can be a proxy for physical activity. And that, if it's true that mental health has an effect on physical activity, then that should be reflected in my steps. And that would be nice because we don't have to ask people how many steps did you do if they have a smartwatch, and that's a big if. But if they have a smartwatch, then that's a way to do it. Same for weight. This is an objective measure we can use. Social connectedness, that's a little bit harder. I think that you could potentially use social media activity as a proxy, but that's very dangerous because social media in itself can have negative and toxic effects. And also, there's massive variation in how people use social media, how active they are. So I would say treat with caution. But it's something that I believe deserves some research into this question of, does the social media consumption and engagement patterns reflect mental health of people doing it? Also, I think, Stacey, you also pointed to the idea that in many languages, there isn't necessarily the words to express how one feels or how mental health is perceived. And that's important because if there isn't a language, then we can't ask a question. And a related challenge is that in some cultures, the mental health is expressed and experienced as a psychosomatic syndrome. So one does not have depression, but one has headache or heaviness, or it's translated with physical symptoms. And so if we don't notice, we would not ask those questions about physical symptoms, or we wouldn't recognize them as effects of mental health. So psychosomatic measurements, I think, are very important as well. Next slide. Okay, how can we measure all of these different indicators? We can, of course, ask the person questions. So that's either self-administered or through a research assistant or a nurse or somebody or a counselor that we can ask questions. We can also try to have a semi-structured conversation. So we have a long dialogue, and through that dialogue, it doesn't feel like, please fill these 20 questions. But through our conversation, we are actually getting to the gist of those 20 questions. But it's not as direct as the questionnaire. That's another option. That's time consuming, but potentially you get better quality because it's based on this interconnectivity and human connection, and not just treating it as a study individual. 360 assessment, by that I mean you don't just ask the person, but you ask their environment. You ask their colleagues, their spouse, their children, their parents. And so jointly, you get different views of how this person is behaving and feeling. And that gives you a better sense than just hoping that your client or your patient is able to express what's going on in their lives and in their mental health. Biometric data I've already alluded to. Healthcare facility registers, of course, if there's a health-seeking behavior component to it, then that should be reflected in the electronic health record systems or the paper-based health record systems. Did somebody seek healthcare and did they go for counseling? And some of those traces may be positive, but there may also be negative traces. So somebody presented at emergency care because they cut themselves. That's not a good thing. So it's important to really look carefully at what was that interaction with the healthcare provider for, and what was done. Was it a counseling session, or was it an emergency relief session? And then last one, I think alcohol, drug abuse is also an indicator of mental health, and the reduction of alcohol abuse might be an indicator of improved mental health. We can ask how many units did you drink in the last week or in the last month, but if we're doing interventions at scale and they have a strong effect, then we should be able to see that in aggregate numbers as well. So the shebeens and the liquor stores should sell less. It can't be that they sell the same and people drink less. That doesn't make any sense. So there's some possibility. You can't of course then link it to an individual, but you can say this community is now drinking less alcohol, and we think that's related to our intervention, for instance. Next slide. Okay. When we try to measure mental health, it's important to be clear, are we trying to measure things at the individual level or at the population level? And you can, if you have measured things at individual level, you can aggregate it and sort of summarize it to the population level, but you can't do it the other way around. So certain things, the example of measuring the sales in the bottle store would be a population level measurement. That's not individual level. Asking a person how many units did you drink in the last week, that would be individual level measurement. Specifically for population level, because it's already aggregated, the precision is typically less of a problem than it is for individual level. So if people don't know exactly how much they drank, and they say, I think 4 units, but it's actually 3 or it's actually 5. If everybody has some random noise added to the truth, and if that's true both in the pre and in the post survey, then the effect of the intervention will be washed out a little bit. It's called attenuation bias in statistics. So having really precise, accurate measurements across the entire intervention from beginning till end, pre-post, is very important. If you have imprecise measurements, you will think that the intervention had a weaker effect than it actually had. And that would be a shame, because you're now not showing the effect the true effect that you made. And a related idea, but very different, is regression to the mean. Oops, I'm not sure what happened. My slides, oh, there we go. Okay, regression to the mean means that somebody who is an outlier is unlikely to stay an outlier. So if somebody is really, really, really happy, chances are that a week later they're not equally happy. And if they're really, really sad, chances are that they're going to be less sad the next day or the next week. And that means if you say, let's find the people who have the worst possible mental health, then even if you do nothing, you are very likely to see their mental health get better. And so if we ignore that, we're going to think we made a big impact, but actually it's just sort of natural evolution. That noise was not random. We cherry-picked noise in one direction, and that's how we got to this effect. So it can work in both directions, and it's important to be aware of it. So we can design our studies and our measurements to factor in this regression to the mean. Next slide. Can I have the next slide, please? Thank you. Okay, I'm almost done. This slide is quite dense. So associative means the one goes up, the other goes down, or if A goes up, then B also goes up. That's just an association. one thing follows another thing in the same direction or in the opposite direction. But that doesn't necessarily mean that this association is also causal, meaning that the one is the cause and the other thing is the effect. So if you hadn't done A, then B wouldn't also have happened. That doesn't necessarily mean the same thing. For instance, to illustrate that, if you see mental health go up, does it mean that the intervention worked? Maybe not. And I've already given an example, regression to the mean. That could be what it is. It could also just mean that things are generally better. Society is better, job creation is better, but you as the NGO didn't do anything special, so it's not thanks to your intervention. It could also be in the other direction. So things don't move. The level of mental health at the beginning, at the end is the same. Does it mean that your intervention didn't work? Not necessarily. Maybe things would have been way worse if it wasn't for your intervention. So we have to be careful to just attach strong statements of effect and impact to temporal trends, to time trends. And one key way to account for this is to have a control group, because that control group represents what would have happened in the absence of the intervention. And so in the last example that I gave, where society is getting worse, in the control group, you would expect to see mental health go down. In the intervention group, mental health stays equally bad, but better than in the control group. And then the difference between control and intervention group is an indication of the impact that the intervention has had. Self-selection bias, what does it mean? If you're doing a study or you're inviting people to be part of an intervention, it's sometimes plausible that the people with the strongest interest in or the most self-awareness or the most self-belief are the first ones to sign up. Also, maybe they have stronger social networks, their partners, their colleagues are encouraging them to be part of this thing. And so that's doesn't necessarily mean that your intervention didn't have an effect, but what it may mean is that if you now were to generalize it and say, as of 2026, it's national policy, you shouldn't be surprised that it's less effective once you go to scale, because your pilot study was not representative of all patients who needed your intervention. There was some self-selection bias. The different challenge is social desirability bias. So that means people say what they think you want to hear, or they say what they can live with. So if it's something they're guilty about or they feel ashamed about, they might not want to admit that. And so they say something that they can admit to, which is not necessarily the truth. One way of catering for that is to normalize the really bad behavior. So instead of saying, how often did you not get out of bed, and then stop there, people might, if the truth is that it's almost every day, you might not want to admit to that. But if you start by saying, was it every day? Then they could reply, no, it wasn't that bad. It wasn't every day, but it was almost every day. Or another example, how many cigarettes did you smoke? Do you smoke per day? 4 packets, 3 packets? No, not 4 packets. I only smoke half a packet a day. So there, you make them feel less guilty about the undesirable behavior. Another aspect of trying to solve for social desirability bias is to make it very anonymous, so in my mind, there's 2 ways of doing it. Either you build rapport, you build trust, and that it's very time intensive, but people are comfortable to tell you the truth because they trust you. Or you do the complete opposite and you don't, people don't know who's asking. It's the robot asking, and they are guaranteed that no one will ever find out that it was them who gave that answer. Anything in between, I think, is at high risk of being subject to social desirability bias. And last slide, I think. Okay. When we analyze data, we see, let's take the example of a pre-post in design. So we measured mental health and other outcomes at the beginning and in the middle and at the end. And we do that in a control group and in an intervention group. If we see differences, that doesn't necessarily mean that we understand how those differences came about. So sometimes it's a bit of a black box. We think we have some theories about, let's say it's a counseling intervention or cognitive behavior therapy or something like that. We don't have to measure every single little step in the mechanical way from intervention to outcome to be convinced that it had an effect. So explainability is good, and the more we measure, the more likely we can explain it if we measure the right things. But it's not a must to prove impact. And then the last thing, transferability. So if we've done a study and we want to convince an investor that we should now replicate this somewhere else, or we should make it 10 times bigger, the funder wants to know, will it work equally well at scale, or will it work equally well in this new community where the pilot didn't take place? What's important or useful is to say, well, let's see how variable the effect sizes were. So on average, let's say some depression index moved from this level to that level in the positive direction. That's the average, but that doesn't necessarily mean that it moved equally much for everyone. And so if we understand how much variation was there in the effect across the study population, and also can we understand what are predictors for a larger or a smaller effect? Maybe it worked better in youth, or it worked better in women, or it worked better in people who were unemployed, whatever the case may be. If we understand predictors for that variation, then we have a stronger chance of also having a sense of how well it will work in some other population, where we can then ask, how different does this new population look versus from the initial population? Yeah, so that's what that transferability points to. And I think that's,
Thank you very much, Prof.
from my side. Thank you.
This is very informative, and it's always the level of detail. We keep speaking about widespread adoption as well as scalability, and the level of detail that you've dissected that is quite important. I like the way you have subdivided it into, what would work for a particular population and what works for at individual level. So thank you very much. And we want to move to Jules to now speak to us. Out of these metrics, which one moves capital, and from different funders, what do different funders look at? And before that, even as the third poll is on our screen, we're taking a minute to respond to that. Jules, we are looking at this as a situation where we are able to measure these metrics. We're using standardized tools to measure our outcomes. But a lot of people are asking, what then do I need to demonstrate to everyone else, who different funders? If I'm approaching a private investor or a philanthropic capital provider, what do I need to demonstrate? So please take it away and discuss this with us. Over to you.
This particular question or my broader presentation? This question?
Close first slide as we wait for the poll responses to come in.
Sorry, I'm interested to see what people say. Yeah, all of above. So yes, my thinking with this particular question, and it will, I'll come on to this in my slide, but of course it depends on the funder. I instinctively went to workplace because that is where there are many more funders able to pay and incentivized to pay. But it is all about incentives and which incentives different funders are responding to. So I'll come on to that, but it's a really interesting question and really interesting to see the results as well. Just perhaps a little bit of an introduction to Kokoro for those that don't know us. We, as I say, we work day to day with funders, and I just want to start by reiterating actually everything that Stacey and Prof said at the beginning, because I've worked in impact all of my career and for the last 10 years with funders in different areas of impact, and metrics have always been the bane of my life. It is so hard, and then mental health is so complex, and so very often when I'm speaking with funders, I try to make sure that we're not getting to the point that the complexity of metrics is leading to inaction. It's, you know, that classic not getting so bogged down or looking for perfection in something that then means that there isn't action happening. Yes, we need to be learning. Yes, we need to be trying to take good decisions. But this is a process. And I guess what I'm going to try and do today is to give a little bit of a sense of some of the mood music, and also the conversations that I'm hearing and some of the actions that funders are trying to take within that really difficult environment. And whereas Prof and Stacey have given huge amounts of expertise, this is really just trying to convey to you some of what I hear from funders more as human beings behind the expertise in the metrics that Prof and Stacey have covered. The Kokoro runs something called the Future Mental Health Collective, some of whom are on the call today, actually, which is lovely to see you. So shout out to you. But the Future Mental Health Collective is about 175 private sector funders, so individuals, families, companies, focusing on implementation, so support of kind of mental health prevention services, access to services. And we really, it started about 5 years ago as a peer-to-peer support group. So sharing ideas, bouncing off each other, sharing learnings, sharing networks. And it is over the years, as funders have got more used to seeing each other, working with each other, knowing what each other's doing, and the trust has been building, we're now trying to really move it towards much more collaborative action and trying to align different types of funder together, so precisely so that it is easier for those that that they are working with and who want to work with them to try and do things in to try and make things as easy as possible, whilst recognizing that particularly now the situation is very, very difficult. So that's the collective. And then the other initiative, which Shadrach and Nasri has mentioned, is the Coalition for Mental Health Investment. And this is a really important one because it's not only about driving collaboration, but it's trying to unlock all the different types of funder that are out there. And not every type of financing is kind of working at the moment for mental health. There are parts of the capital stack that are simply not engaged in mental health really in any serious way, particularly when it comes to institutional funders. There are many reasons for that, but what we're trying to do is to learn from other sectors, and particularly other areas of impact, where different mechanisms have been used to de-risk and to unlock different types of capital. So a lot of this is, I mean, I geek out on it, I love it, but it is quite sort of systems change level work, but all with the aim, actually, at the end of the day, of trying to empower people like you on this call who are actually doing the work day to day on the front lines out in the real world. So forgive me if it sounds yeah, kind of the techie stuff. I'm really just full of admiration for those doing the actual work. So just on to the first slide. So just to kind of go back to what I was saying about really understanding the funder and trying to understand what's motivating them. Within the collective, we see every type of funder. And it's always really interesting to actually ask the question about what it is that's motivating them, what it is that they want to see. Is it an impact return? And we can come on to what that might mean. For some, they actually really want to preserve their capital so they can keep doing the work, and they want to see an impact return. So they might be spending an endowment and they want it to be a sustainable thing. For some, it is a financial return. For some, it is a financial return and an impact return. again, you've got to think about how big an impact return, how big a financial return over what period of time. This question of sustainability is an increasingly important one. For some, there kind of used to be a bit of a model of, well, I'll do my bit now, and then I'll hand it over to a different philanthropist, say. Whereas now there is a growing desire to take higher risk, but in order to try and be a bit more catalytic. So it's like, can I take a risk with something that is less proved, but that I think could unlock different types of funding, or that could become sustainable because it's empowered the local community to do X and take it on themselves. So, and I'm willing to take risk for quite a long period of time. I recognize it might take 5, 6, 7 years, 8 longer to set something up, but I want to be able to see that trajectory over time. So the types of philanthropic motivation are changing. I would argue that potentially it is particularly so in mental health, because a lot of the funders that we've seen come into mental health to fund are self-made entrepreneurs, many of whom have their own mental health journeys, and they bring that entrepreneurial mindset. So it's less the kind of, perhaps some areas of quite traditional philanthropy. Some of the funders in mental health are themselves hugely innovative, hugely entrepreneurial, and you see that coming through in the types of philanthropy as well, and the willingness to take risk. So, but when you're thinking about funding and metrics and which metrics move with the funding, it's always thinking about which metrics move which funder and understanding the incentives behind them. Next slide, please. So just to speak a little bit about philanthropy, and I'm going to speak about investment as well. I realize that might be less relevant for this audience, but it does influence when we start to think about metrics, even within philanthropy. So just to speak about some of the conversations that are going on within the collective at the moment, within different groups, there is a lot of peer-to-peer support about best practice. And again, none of this is new, but I just want to be reassuring that these are the conversations that happen a lot around trust-based grants, around multi-year, and about a huge kind of awareness that metrics are just not perfect. And for so many situations, particularly low resource settings or settings where clinical staff are very short to come by, it needs to be that we need to do better. And so a desire to kind of, where possible, potentially to even co-create with the implementer on the ground, to work with networks. So for example, trying to support collaboration, sorry, I meant to say Coalition for Scaling Mental Health, which is trying to think about actually what is a metric that is more culturally appropriate, and that would resonate more than your standard, more clinical measures. And I think it's just perhaps to add, particularly in this context of where a lot of development money has been pulled and taken away, a recognition that quite a lot of organizations have been hit with, for example, money that was going to an RCT, a trial, to be able to create data, and yet that's not the frontline service. And so when the funding has been cut, that is the first thing that has been cut, completely understandably. And so I think there is a recognition from philanthropic funders that yes, that obviously funders want to know that their money is going to be well used, that it's going to have the impact that they want it to have. At the same time, there is a recognition that the metrics are not perfect for so many contexts, and that the capacity to really measure to a very high standard has got even harder. And so there is a real focus on what funders can do to make this easier, better. As I say, working with those who are doing the implementing to try and to co-create and to pool ideas. There is a group, actually, just to give one example of where I think funders have come together really, really well and aligned around incentives, is the iconic co-impact, sorry, I've completely forgot, the mental health, the youth mental health collab, the iconic collab for youth mental health, which has brought together a number of funders together to provide multi-year really quite substantial grants around a single process, a single application process, and trying to, as I say, trying to make sure that it's rather than lots of small grants and lots of different processes that effectively put people into competition, trying to get to a point where it can be a more collaborative process all around. There is an initiative that has not yet been launched, but again, is a conversation, and we're working on it, particularly focused on community-based organizations and how funders that fund already and funders who want to fund community-based organizations can again come together and try to make it easier for those that are doing the frontline services but don't necessarily have huge amounts of resources to be kind of getting into very high levels of data collection. In short, this is a horribly long way of saying, and I'm going to come on to the investment, mental health data as its own field is rocketing, and we come on to think about it, but within low resource settings and within different cultures, we have so much work to do, and I think we need to do it together. So genuinely, all ideas welcome. And yeah, I say this off the back of actually 2 very, very good presentations on what people are already doing. So I'm just saying funders are very aware that it is a difficult situation and that we want to be part of working with implementers to help. Next slide. And this perhaps just captures some of what Prof and Stacey were saying. So these are obviously the metrics that funders do look for where they're available. Yes, the validated improvements in symptoms, whether that be self-reporting or others. Huge appetite for the proxies, so where you can show correlated outcomes for all sorts of other sustainable development goals. Many funders don't just fund mental health. And so this is a really valuable piece of the puzzle where people are able to show other angles as well. Sometimes there are easier metrics in other areas of work that can make it very compelling if you've integrated mental health programming, but you want to show multiple different areas of impact. Again, given the broader context, I think there is a growing amount of support for these system change pieces, the policy, the advocacy, the community capacity bit, workforce, mental health workforce, so training up peer-to-peer, lay workers, etc. And then this point about sustainability, so being able to show cost effectiveness, capacity to sustain, particularly really, really important. So the next one, I thought it was just worth mentioning investment because the big trend that we're seeing here is, I've described it as an explosion in opportunities for mental health data. And so on the one hand, you've got this incredibly difficult environment for those trying to provide support on the one hand, and on the other hand, lots of funding going into very innovative ways that are making the most of artificial intelligence and all the different kind of explosion of science and tech that we're seeing, which is really exciting, but still fairly nascent as a field, but is growing incredibly quickly. What we're seeing from a funding investment point of view is therefore a very quickly sharpening desire for very good metrics and very well-backed business cases based on very good metrics. And so there is an interesting trend where you're starting to see for-profit investors giving grant funding to for-profit companies to expand access to their innovations and to their data collection, because the desire is to be able to make sure that things that are coming into the world that are making the most of all of this great science and tech are reaching as broad an audience as possible and are being informed by as diverse an audience as possible. Now, this is still only small. I don't want to overstate it, but I did want to reference it as an example of what I think is a really important trend, that there is a bit of a merging of some of these different types of capital, because the more people involved with different types of incentives, the easier I think it is to actually scale, because you've got different parts of the financial system working together. the very last bit that I just wanted to mention, sorry, last page, is just about blended finance, which I was saying about different types of capital coming together. You've heard already from the experts in this, but the last bit of metrics that I wanted to mention is this ability to try and show savings in existing budget lines. So that might be for a government department, it might be for a city, it might be for a company, but it's always so much easier to save money that's already been allocated than to persuade people to give new money that's not yet been allocated. And so I just flagged that as, again, as the metrics are getting better and better from a kind of science and tech point of view, the ability for proofs of concept to be made in one part, in one place, in one area, and then be, sort of learned from in other areas, and mental health as a whole field, for that sense that the things that feel incredibly obvious to us working in it day to day, but can still be a blind spot for a lot of other leaders and funders. The more that this is happening, and then the more that we're proving the case, and the more we've got the data to prove the case, I think the stronger and easier the argument becomes for all of us who are working in this sector. I'm really sorry that I feel like I haven't done a good enough job, but I hope that gives some sense of what the funder community is talking about.
Thank you, Jules. This is wonderful. I'm happy that you are able to bring in the investment perspective. A lot of people today are asking, I mean, if you want to get some money from an investor who wants to see what the money is going to do, what are the outcomes, how else do you make your case that you are going to actually bring that money back? So that element is quite important, and thank you for highlighting that, Jules. I want to bring in Pavel now talk to us about the tools. I know Stacey highlighted this at high level, but we are going to get into these tools and how we can using the metrics that have been highlighted. But first, let's take a minute to respond to our fourth poll as we wait for the responses from those who have already picked one of the choices in the responses. So we want to look at the tools. And Pavel, I know a lot of people are asking this, which kind of tools do we use? I am in a rural setup in some remote area. What am I going to use to measure these outcomes that we keep talking about? The deployment settings, you are deploying an intervention in a developed country or a developing country. Do we use same exact tools? Which one would you recommend? So please take this away.
Wonderful, wonderful. Thank you, everybody. Let's dig in. And in fact, a lot of what Jules said, we'll build on that and hopefully kind of anchor it in some actual pieces that you could take back and kind of implement. Let's start with the first slide. I'm going to give a quick context about our work, just a very brief one, so you can all kind of contextualize where we are and what we do, and then we'll dive right into the actual metrics. We work in Uganda. Uganda is maybe not dissimilar to many of the countries that you work in. A single % of the healthcare budget is allotted to mental health. There are 50 million people in Uganda. If you do the quick math there, that's a single psychiatrist per million people, and about a 90 to 95% treatment gap for folks that need services but are simply not available to them. Next slide. Well, I've had the privilege of running an organization, a small one, but resilient and growing, that, as I had mentioned, is really looking to see how mental health can become a routine part of primary care. The idea that they're not detached or stand alone in kind of their silos. How do we ensure that they can provide or kind of connect to provide more of a holistic or total type of care, and by virtue of that, enable communities to thrive emotionally and physically? We've been operating in a single district in Uganda for quite some time, but this year we've expanded. It will be in multiple districts and continue kind of our plight to really see this to come to true. But in the last 5 or so years, our team, all Ugandan, have provided over 23,000 counseling sessions over that time span. Next slide. And our sweet sauce, kind of what we do is what we call a stepped care intervention. Now, quickly rush through this here. Prior to us providing that very first step, that interpersonal counseling, it's critical, it's incumbent for us to actually deploy some of these clinical assessments. Once folks score a moderate to high depression symptom severity, at that point we enroll them to start interpersonal counseling, a relatively ubiquitous type of treatment, really kind of born from group interpersonal psychotherapy. We all are familiar with that, or most of us should be. The step above that, if someone isn't improving by virtue of that type of treatment, is something called problem management plus. So at this point, not only looking at depression, but also wrapping into that adversity. And I think this is maybe the most important point here. We're human. We're fallible. We're not going to always have 100% treatment or success rate. So it's key, vital to have a referral arm. And in most of the settings that we operate in, the mental health infrastructure may not even be existent or really lackluster. So we've had to get a little bit gritty and creative to see how we can really activate these referral pathways. And at least in Uganda, you have psychiatric nurses, you have a regional referral hospital, and we deploy capital. We actually provide money to some of these clients to ensure that if they're not benefiting by way of our intervention, they have enough money to actually get to the place that can provide additional services. Next slide, please. All right. Now let's get a little bit geeky and nerdy here. So these are the individual and clinical measures. Some of these you may have a little bit more familiarity with. The others you may not. But hopefully at the end of this, you'll have a little bit more as it relates to kind of how we're approaching measurement, and maybe some of the ones that you can also borrow. We don't have all the answers. These are ones that we've kind of tracked and really evolved through time, a lot of trial and error. And to Jules's point, attempting to also kind of be receptive or responsive to what the fundraising or philanthropic field is also pushing forward. Up next slide, please. The PHQ, probably the most universal, the most ubiquitous, focuses on depression severity. And I think the real caveat here, it's short, it's quick, it can track the clinical symptom change over time. And in fact, we as an organization at FindMind, every single session that we provide care, this is something that we administer, it's quick. Some of the questions for folks who are maybe familiar allude to a newspaper or television. And I think the interesting point is, right, in the context that we work, folks may not have a newspaper, folks may not have a television. So we've had to slightly adapt that for the cultural context to still retain the spirit of what that question is getting at. Next slide. Now, what the PHQ doesn't do, the WHODAS, which is the World Health Organization Disability Adjusted Scale, does. It actually starts to look at the functional impairment by way of the symptomatic impact that is being affected or that you're feeling by way of the depression. So it actually shows if recovery or how recovery translates into real world functioning, going beyond said symptoms, and at this point, actually measuring life impact. Next slide. Now, we as an organization also had a very hard time of really determining the risk level of suicide. And again, through trial and error, stumbled upon this particular tool. This is the Columbia Suicide Severity Risk Scale. Also incredibly quick. I think it's maybe 6 or 7 questions in total. But at the end of the patient health questionnaire, question 9 actually asks about your intentions or your thoughts of potentially killing yourself. If anyone scores anything besides a 0 on that question, this particular tool is immediately triggered, and we're able to, in fact, kind of glean or understand what is the risk level to ensure that that particular client has the proper safety, and it informs the proper triage or referral pathways that need to be implemented. Next slide. Now, this one is maybe slightly more unique to what folks are kind of accustomed to. This is the health-related quality of life. Now we're starting to get into a little bit more of the health-related quality of life, meaning how is it impacting actually your life satisfaction? Now, this particular tool, it looks at subjective well-being and also the daily limitations. A lot of the questions actually hinge about healthy days or unhealthy days. How, again, is it impacting your activity limitations? And the really cool thing is that it anchors not only the clinical, but also the functional data in lived experience. Next slide. Now, spillover, fundamental. My mental health doesn't operate in a silo. It's a complex social issue that bleeds in, that has knock-on effects in many different parts of life. And this one specifically measures the ripple effects as it relates to family, work, or community. And we kind of developed our own questions here that look at economic participation, child food security, child education, gender equity in household decision-making, perhaps household mental well-being, and also life satisfaction. Those are really interesting questions for us. And I think we have a responsibility as an organization to also understand the community mapping within our kind of operation, work, or geography. By virtue of that, if we are not able to provide additional economic support or child food security, are there other organizations in the community that can, in fact, offer those services? So I think, again, by virtue of this kind of tool, we actually have a better sense of what those impacts are as well. Next slide. Now, we're going to shift a little bit and look at the economic and comparative measures. These are a little bit more technical, if you will, and a lot of kind of the back end of this is actually the analysis by way of the first 5 tools that we talked about. Next slide. Now, the DALY is the Disability Adjusted Life Year. And here we're actually referencing the global burden of disease and the disability weight of that. It's the years of healthy life lost due to illness and disability. Now, the really neat thing about this is that this is a standardized global health currency for all or for many diseases. And in fact, it allows you to compare mental health to those of which of malaria or HIV and so forth. And by virtue of those couple, the initial ones, the PHQ-9 and the HUDAS, we're able to translate those to improvements in reductions in disease burden. So our goal here is that we want to avert disability-adjusted life years. Next slide. Now, kind of the counter of that, or the other end of that spectrum, is a quality-adjusted life year. Now, this actually looks at years of life, again, weighted by quality, 0 indicating death, 1 indicating perfect health. We're hoping to gain QALYs per person, or actually look at kind of the total QALYs gained by virtue of a program. Now, this is common in cost effectiveness, and I think is really kind of encouraging or spurring more of the health economics and policy making. Again, here, we're linking the clinical and the functional gains to the life years gained at large. Next slide. Now, the WELLBE. The WELLBE is a relatively new metric that has kind of come out here not long ago, coined by the Happier Lives Institute. A WELLBE is actually a unit that represents a single point of self-reported life satisfaction on a scale of 0 to 10 for 1 year. Now, it looks again at the life satisfaction and the length of the life, and it captures those well-being gains more directly than the DALY or the QALY, and is especially suited for mental health. So a couple of those questions from the HRQOL can be proxies to actually understanding or gleaning what a WELLBE is. In our spillover questions, we actually have a question that we look into life satisfaction. And on a scale of about 0 to 10, that one is a little bit more direct and kind of can inform what a WELLBE is in terms of the metrics that we collect. Next slide. And cost effectiveness. This one is tantamount to any sort of program, I think, really having scalable and durable and systems change at large. A lot of the contexts that we work in, as I mentioned, maybe have lackluster mental health systems or services, and a lot of people are struggling. So in order for us to really affect large change, it's prudent of us to also decrease that cost. Or what is the cost per DALY, QALY, or WELLBE gained? Now, this actually demonstrates the return of impact and now compares mental health investments with other sectors. It pulls together all of these outcome metrics into something that I think can really be appealing to more of a funder-facing, evidence-based that looks at efficiency and value. Next slide. And kind of a quick here takeaway slide. I'm also still a strong proponent that as much as there should be focus on quantitative data, there is tremendous value in anecdotal and qualitative data as well. A story is deeply impactful, it's powerful, and often I think you need to present both. But the spirit, at least, of this conversation was about these metrics. Now, when we speak about these metrics that FindMine is collecting, we're not collecting them all the time. The PHQ, yes, that's our core anchor. The HUDAS, we're collecting about 40% of the time. The Columbia Suicide Severity Scale, that's only collected when triggered. The HRQOL is pre and post, and also those kind of economic and comparative measures, those are on the back end. So imagine if you're having kind of a recipe or a large pot of soup, be discerning, right? Don't throw every ingredient into that pot of soup, otherwise it won't taste quite good. So kind of my proposition here is, I think actually less is more. And then the very last point here is considering scale. Now, what do I mean by scale? Scale in kind of two forms here. Scale meaning that the problem is very large. So how do we reduce, again, the cost of the work that we're doing? But in the same vein, if we're trying to act with some sort of urgency and expediency, imagine what the community health worker or your counselor, your non-professional is providing. If you saddle them with so many different assessments, I think it actually takes away from the impact, the trust, the relationship building that individual can actually do with that particular person, and to actually kind of engage and provide more of that mental health literacy. So we need to be a little bit more discerning of how we're kind of assuming or empathizing in the feet of that counselor to make sure that the program still retains more of that research value, but you're also able to do the work on the ground as well. That's all I have. Thank you, guys.
Thank you very much, Pavel. It's always the passion and excitement of presenting this. I'm so happy that you were able to do a deep dive into these tools. A lot of us were asking, what do we do when I'm having an intervention in a remote setting, or even in a developing country or developed country? What do I use? Very wonderful you presenting that. I'm taking away quickly that data tells the story that unlocks funding. That has been demonstrated. It's now time to hear from our participants as well. There has been certain questions that have been put in the Q&A session. I want us to quickly go into that, even as we go through the pre-selected questions that our participants did share with us while registering. But I do have one interesting question in AI. One of the participants is asking, in cases where we're using AI in mental health intervention, when AI is proposed, what types of metrics can be established at the start to ensure that any negative impacts from the use of AI are monitored so that adjustments can be made in the program or model? My panelists, please, I need one of you take this up so that we can hear from your perspectives. What do you think? Yes, Stacey, please feel free.
I don't have an answer to the specific question, but I do have a process that might help. Look, we remain so grateful for the leapfrog, the ability that technology has given us, especially in low resource settings, to leapfrog in areas of public health, including mental health. So there's some amazing organizations using technology and AI so that we can increase our reach and the depth of support to last mile communities. There's no doubt. Coupled with that comes some very real risks, and we've heard about it a lot recently in some good studies around how people are trying to use AI almost as a counselor and the negative impacts on that and that kind of thing. So we also acknowledging the other side of this. I think it's very important that as we start moving towards wanting some kind of standards, benchmarks for our programs, to think about perverse incentives and unintended consequences. So this is not an answer to this question, and it's not a specific answer because AI is a tool. Just like how surveys, when we went out walking door to door at health facilities or homes, was a tool. It's just that the scale of it makes it quite dangerous, but also quite useful, right? So I think we all, especially in the mental health space, need to be very thoughtful in our process of defining indicators, of how we measure this, how we evidence it, how we verify it, and how we evaluate it. And part of the outcomes-based process is going through things like unintended consequences and perverse incentives, but anyone can do it, especially if you are using these kind of new technologies. I think we must always remember in healthcare that we are people who are caring for people and caring for each other, Ubuntu as a community. So technology only enables, it is not in itself the answer. So colleague, I'm happy, I'll leave my details in the chat as well, if you want to have a conversation about this, because definitely as Africans, we don't want to be left behind by the AI train. So thank you so much, Shadrach.
Thank you very much, Stacey, for that. I think that's very informative. And there is another question coming up on why are we not mentioning the WHO's 5? Is there any general sentiment, especially from funder lens? And Pavel, I want to put this to you, tying it in with another question that we already got about whether there are any specific tools that you'd recommend for measuring these outcomes at rural level, especially when you're working with the rural people at community level. Are there any specific tools that, and then Jules can tie it up while talking about the metrics that funders would look into when you're also doing rural kind of settings with your intervention. Pavel, let's go first. Thank you.
Perfect. But the WHO 5 is absolutely a fantastic tool. We work in close contact with the Global Mental Health Lab at Columbia University. They've been extremely generous with their time and gracious, and a lot of these questions about particular metrics and impact measurements, I've kind of broken bread with them about, and they have been incredible proponents of how about you trial this out. And in terms of the rural context, FindMine exclusively works in rural context. We work in northern Uganda, just shy of South Sudan, a particular area that was in civil war for decades. We're just expanding into the largest refugee settlement. So I'm happy. I'll leave my email as well. We did not have quite enough time. I just gave kind of a quick primer about the tools, but I'm very delighted to explore how we actually adapted them. What does it look like on the ground to see a counselor administer them? And how do we operationalize a lot of these metrics? And again, just a quick note, we don't know everything. There are likely tools out there that are better for your context. And I think that the real beauty of this is as FindMine continues to grow, we'll continue to modify what we administer as well.
Thank you very much, Pavel, for that. Always a pleasure. Jules, please, in less than 30 seconds as we wind up.
No, I was just going to reiterate, Pavel's right. There are organizations that have somehow really managed to scale and to measure exactly in the way he's describing. There's another initiative called Empower out of Harvard Medical School, which again, people may know in terms of training up lay people and being able to measure. And so it absolutely is possible. And I think I'm just always very conscious that there are very small, locally based, community based that haven't necessarily got to that scale yet. And so being able to learn from those that have done that is really important, and kudos to those that have.
Thank you very much, Jules. Always a pleasure. This has been quite a very insightful conversation. We can never exhaust this conversation, and therefore we continue discussing this offline. Even as we close, a lot of this conversation is going to go on in our upcoming conversation. in our conference from the 3rd of November to the 5th of November, under different themes ranging from building resilience from within to private sector engagement. And of course, catalytic capital. How can we unlock private capital to scale investments? A lot of audience that we're expecting very powerful, including investors and funders, policymakers and governments, social entrepreneurs will be there, and innovators, as well as thought leaders and academics. Please, for the purpose of this particular webinar, AVPA is giving you a 10% discount on this. Please feel free to scan this QR code from wherever you are. We will also share this together with the report and the recording with everyone who was able to attend this, so that you can claim this discount. This will be valid for the next 1 week. So please feel free to use it so that we can continue having this conversation even in person during our conference in November 3rd to 5th. Thank you very much for getting time to attend. Looking forward to continuing this conversation offline. Bye-bye, everyone.